Yeah, there's an old it's from I guess the 70s or maybe the early 80s. Dave Frank Zappa has this song where they're in a band and the guy gets an STI and he said, I got the gonococcus, so definitely like Dan
Amazing.
saying a little bit too much for ASHP, but
Oh,
there was
for
no
sure.
profanity or anything, but too much.
You gotta try to find where the line is.
Hmm.
Well, I found it when I invited one of the physicians to share a talk with me, and all of the audience complaints were about the amount of profanity he used during his presentation. I actually think that was the last time I was invited.
Us EM group is a rowdy bunch, especially if you get a drink or two in us.
That was from Arizona, Dan?
Yeah, Frank Lavecchio.
Yeah. The EM meetings are so different, even the ones that are more on the level or that more the academic ones are even, a little bit different. But
And
Hello, everyone.
hey, what's up, Nick? You working?
Yeah, Grady. I think Sam cursed me on the way in.
Oh gosh.
I saw him going out to the parking deck, and he said, "Oh, you're gonna have a great shift." And I was like, "Thanks, Sam."
It always goes like that. My shift
Yeah,
was great today until my partner was 30 minutes out, and I was like, "Come in now." It's gotten
I
so
can always
bad.
I can always tell when our black cloud leaves her
uh,
house, and I'll have a great day, and then I'll text her. I'm like, "You're on the road, aren't you?"
Well, we've started calling them Abby shifts, and my counterpart's name is Tyler in Tyler shifts. He's like, "You just got here, didn't you?" I'm like, "Yeah." He's like, "I know because a full trauma just rolled in."
well, the
Yeah.
other evening
Oh,
pharmacist that works
sorry,
at
I didn't see
Emory.
yours. Yeah. Yeah. Oh, yeah, yeah. He's good.
So the other Emory
Yeah.
pharmacist that work
Malia,
with
come here. Hey, come here,
Betsy.
baby. Oh,
Betsy, you're off mute.
sorry.
That was like the other Emory pharmacist that I work with call her the dissection queen because always when she's working is when all the dissections come in.
Oh wow.
That was me in residency. I got 12 in 1 year.
That's a lot for 1 year. Gosh.
So sorry.
Well, the weirder things I have to deal with lately, I feel like all the genetics patients come in when I'm working. When I'm speaking genetics, I'm talking about mitochondrial disorders.
They have a special unit for that, Nick?
So Emory is one of the few hospitals, or maybe the only one, that has like a genetics service. So it's basically all the patients now that like have survived past childhood and are now adults. Before it wasn't a thing, but now since they're receiving really good care and, from both caregivers and staff, whenever a lot of them are now making to adulthood. And so now they have to have a genetic service, which also looks at adults. There's a lot of gray area though with a lot of the dosing of the meds though, because a lot of the meds dosing is still kind of peds related, where it's like based off of like BSA for some of the meds, which I don't know if they know if like true caps for adults, because I don't think it's been studied like into adulthood.
Yeah. I guess with all the new treatments, it's kind of new ground there.
Luckily though, we have an order set. We have an inborn errors of metabolism order set that we have in place for the providers, like because another one that works really hand is our nutritional support team. Really works hand in hand when those patients come in, just because a lot of their diet, it's a lot of it dietary issues as well. Like they have to have low protein diets. Uh, Usually when they come in, there's like specific drips that they want them on, like D10 and half NS, which is only found in that order set, so it's pretty specific. Also fancy stuff like arginine and ammonol, a lot of drugs that I didn't even know existed until I started working
Yeah, most
at
places
Emory.
don't have that stuff.
Yeah, we just had a case actually like that too, Nick. That was the very long chain acyl-CoA dehydrogenase deficiency VL clad or whatever,
Yeah.
and he had this whole sheet of like half NS with like D10 with potassium, all this stuff, and yeah, it was just kind of a cluster. So yeah, I feel you there.
Yeah, luckily our order set's built, which is great for providers. Sometimes though, I just always have to steer them when I know that they're coming in. Sometimes the NST will actually give us like a heads up that that they're coming in sometimes, because sometimes it's relayed through them and genetics. I don't know if they got a group chat or whatever, and so sometimes the patient's family members will message like, "Hey, we're coming in because they're acting a little weird," and especially with the mitochondrial disorders, the ones that are really problematic. With the Krebs cycle disorder ones, is that they'll usually come in with super high ammonias and they seem fine, and they slowly get more and more altered, and it gets to the point where they're running like tons of drips. They'll be getting like Ravicti's, usually their home med, which is usually that they're on. But then they'll, if they're too altered to even take that, then we'll have to start the ammonol and arginine and lipid emulsion running for them, and then the D10 half NS. Then sometimes intubation, and yeah, it can get pretty bad.
Yeah, in the crazy world of emergency medicine that we all live in, my patient had the letter with them that had their specialist phone numbers and what fluids to start immediately and all of that. So I think I hit the lotto on that one.
Oh yeah, you got pretty lucky if you're if you're not used to it. A lot, you know, it might be useful though, is that if you have Epic, just to add all that stuff in a flag in the chart in case they ever come back.
Yeah, it's a good idea.
I had one of those recently too, where they came in with this weird genetic disorder and they had the paperwork from their provider. And I at first I was like, yeah, okay. But then it had the fluids and what meds and what to do with this, and it was great. So yeah, I scanned it in the chart and made a note.
Yeah, the other weird one that we sometimes see is like someone, we had like a Malas patient come in. It's like they're having a stroke and it's new. Oh, it's like a nutritional mitochondrial disorder. Like what? That, and like Malas can cause you to have a stroke. And again, it's kind of like similar treatment.
I feel like I'm gonna walk into this tomorrow. I feel like you guys are speaking this into existence.
We've got a lot of people joining, so I think we'll get started in just a minute. But yeah, that stuff sounds really interesting. I have yet to see one of those, so I have not been so lucky. But
Next out of pocket cases.
Oh,
Looks like
God.
Nick's up.
Oh
there
God,
you
no!
go.
How about you? You're the one who's. No, I guess I could talk about it because we have order set and everything. So I guess I can throw myself under the bus. I could probably have a whole series on rare diseases, especially what I see in my hospital.
For sure. At the university setting and with that area, absolutely. I think we'd just give it another minute. Thanks everyone for joining for out-of-pocket cases. We're excited to have our presenters, and we'll get started in just a couple minutes. All right, everybody. Let's get started with today's out of pocket. Again, thanks for joining us. Have some good presentations today. The first one talking about disasters, Dave Patelin. Dave, if you want to go ahead and take over.
Sounds good. Let me see. That's just slide control at the top. Is that what that looks like? Or I'm able to go ahead and just start going here. See,
Yeah.
can everyone see the slide switching okay?
Yep. Looks
Perfect.
good.
All right. Well, welcome everybody. Hopefully everybody can hear me okay. Thanks for joining the out-of-pocket case series provided by Society of Emergency Medicine Pharmacists. Excited to see everyone joining. So I'm not sure if everybody's seen a lot of the recent news around the country, but there's hundreds to thousands of mass casualty incidents per year all around the country. These range from small local incidents to larger scale mass casualty incidents. And today we're going to be talking about one of those, titled From Reactor to Response in Resuscitation, Hydrazine Exposure Management. My name is David Hutland. As John already introduced me, I am currently the emergency medicine clinical pharmacist and emergency medicine PGY2 program director at UW Health Swedish American Hospital in Rockford, Illinois. Our emergency department volume is around 70,000 visits a year. We're a level 2 trauma center, emergency department approved for pediatrics. And I've been here for 11 years now. I have nothing to disclose regarding this presentation. Today's objectives, we're going to recognize the toxicologic profile of hydrazine, kind of a spoiler, and apply evidence-based principles to the assessment and management of exposed patients, analyze communication challenges encountered during a mass casualty event, and identify strategies to improve coordination among healthcare teams and external agencies. And finally, assess and man mass casualty incident response procedures and identify opportunities to enhance institutional preparedness, surge capacity, and operational readiness. This brings us to our mass casualty incident. So Byron, Illinois is located about 20 minutes south of Rockford, and this incident occurred March 10th of 2026. Around 5:45 p.m., our emergency department was notified via police officers, more specifically a sheriff's officer, of a mass casualty event at the local nuclear power plant. Kind of nice picture. It's in the middle of the cornfields here in the Midwest, but you got the reactors and the smokestacks you can see rising up from miles away. It's kind of crazy. And they do tours too, if anyone's ever interested. But at this point, that is all that we had heard. And this wasn't even via official routes. We were unsure of how many victims there were on site, unsure if radioactive material was involved. And our ED, we started to coordinate a tentative response and started gathering resources and discussing with leaders. So as the information started to trickle in, discrepancies started to pile up for us. The emergency management team was on site, and this was the county emergency management team, and this is actually a county over from us. And then don't forget, you also have your hospital emergency management team and then other EMS management teams as well, all trying to share information. So we began to receive reports of anywhere from 5 to 10 plus patients exposed to a chemical spill, but unsure what chemical at the time. As we go through the timeline a little bit, the first report was from Illinois Poison Center when I had reached out to them, and they said they were notified and were dealing with a hydrazine exposure. A little bit further down the line, after patients started showing up, we had a second report from our hospital's emergency management team that this could be sodium metabisulfite. And then finally, a third report was from a couple of the patients I was speaking to that worked in the facility with these chemicals, who specified that it was hydrazine. So being the EM pharmacist that night, like I said, I had reached out to Illinois Poison Center to see if they were aware of the incident, to prepare resources and for guidance from them. It is important to know too, which this was news to me from them, was they had their own internal incident command structure at the Poison Center, which I thought was really neat. They were communicating through each other through Teams chats with the toxicologists, with the tox fellows to get just-in-time information to those frontline poison specialists taking calls from the hospitals in the area. I did take them by surprise though, as they had been told that all patients from the scene were going to be transported to one of the 3 hospitals in Rockford. That was not our hospital. for this. So they had to shift course pretty rapidly when they heard that we had ambulances inbound with patients. Primary exposure for these patients was inhalational and dermal. So given this information that I've already shared with you, what chemical do you go with as this information is changing so rapidly? Hydrazine was significantly the more dangerous toxic of the two agents being reported, which we'll discuss more in detail in a second. Sodium metabisulfite, though, is mainly an irritant and asthma trigger, and that's kind of where the toxic symptoms end for sodium metabisulfite. The EM team here and Illinois Poison Center made the decision to go with the initial report as well as what the patients flowing in who worked with the chemicals reported. And that was that ammonia smell, and they knew it was hydrazine. Sodium metabisulfite has more of a burning matches, rotten egg smell to it. So diving into hydrazine, hydrazine is an industrial reducing agent. So it's used, as you can see, in these big piping systems. They help clean the system and keep rust from forming. They're also used as a propellant in rocket launches and aerospace. Exposure to hydrazine is the lungs and skin rapidly absorb the chemical, and this inhibits pyridoxine kinase and glutamic acid decarboxylase. To put it in easier terms, hydrazine depletes the pyridoxine, vitamin B6, resulting in impaired GABA production. From this, we see CNS effects, liver effects, and respiratory toxicity. And the key symptoms that we're going to see presenting from these patients is airway irritation, cough, dyspnea, severe cases, pulmonary edema. We're also going to see headache, dizziness, nausea, CNS depression, and then in these more severe cases, seizures, which is going to come from a buildup due to the lack of conversion from glutamate in the process to GABA, as well as the depleted GABA because of this process as well. And finally, delayed hepatotoxicity is possible as well. So how are we going to monitor and manage these patients? So we're going to take vitals, mental status checks to watch for that CNS complications. We're going to get a CMP, a CBC, a pH, and a lactate. So the importance of the pH and lactate is because hydrazine also blocks the conversion of lactate to pyruvate, and this causes lactic acidosis that we're going to be on the lookout for. We're going to get a chest x-ray as well for anyone with pulmonary symptoms, again, looking for that pulmonary edema. And hydrazine exposure can also precipitate methemoglobinemia, and so it's important to pull a level, and management of this is going to go beyond the scope of this presentation. So how are we going to manage these patients? So first, we're going to decontaminate them. We want to make sure that they're stripped of all their clothing and belongings, make sure that any chemical that is on them is removed. We also want to ensure staff safety as well as safety for the people on scene that are helping with these patients. Getting them the fresh air, obviously, is that initial, intuitive step to get them outside of the exposure area. And then once EMS starts arriving, that 100% oxygen with assisted ventilation is needed. Our mainstay is going to be beta-2 agonists such as albuterol and corticosteroids for bronchospasm. And then our primary antidote for this, if we haven't discovered it already, with pyridoxine B6 being involved, we're going to give this and a benzodiazepine for seizures, CNS depression, or if they start having lactic acidosis. The dose for pyridoxine is 25 milligrams per kilogram IM or IV, up to 5 grams. So if anyone's doing back of napkin math, most hospitals do not stock enough pyridoxine to manage multiple severely poisoned patients. So for a roughly 70 kilogram patient, your dose would be 1,750 milligrams, which if you're not as familiar with the vials and how pyridoxine comes, it's supplied as a 100 milligram in 1 ml vial. So you're going to need 18 vials for your average 70 kilogram patient for their first dose. As far as disposition of these patients, you're going to observe until they're asymptomatic. In the ER, any sign or symptoms of CNS-wise or persistent pulmonary symptoms beyond 6 to 12 hours of observation should be admitted for further management. So back to our cases. So I've listed them all here along with some notes that were literally just scribbled on the back of some recommendations and MSDS sheets that I was getting. We had a bunch of patients with numbness and tingling, hands and feet, dizziness, shortness and breath, drawing attention to patient 3. He was a security supervisor who was running around, but he was unsure if the running around was causing the coughing, or if it was the chemical exposure, which, you know, made a few of us chuckle, and we knew that he was okay. And then we did have walk-ins, patients 4 and 5. One of them was at the site working, and notably patient number 5, she was the spouse of patient number 4. She was in the car with him from 30 minutes from the scene, but she actually works at the plant as well and was exposed to hydrazine 6 months prior, and was intubated for the exposure, which, you know, that draws other head scratches of, you know, 2 incidents in 6 months. And then patient 6, most notable, discovered the spill. I talked to him personally, and he said it was a leak from a fitting on the 50-gallon hydrazine tank. And he had thrown oil dry on it, and there was a few ounces on the floor, and this was per his protocols. He had some initial throat irritation, but, you know, this was key. And, you know, I was the one relaying this to poison control and saying, like, listen, this guy hands-on with this stuff. I think he knows which chemical we're dealing with. And then as well as patient number 7, 20 years he's worked at the plant, has smelled hydrazine before. He knew it the second he got off of an elevator, that he smelled that ammonia smell. One other comment I did want to make about cases presenting. So this was, you know, at a nuclear power plant, so very secure building, those kind of things. If this happens out in public, you might get some patients that are coming just out of anxiety or the fact that something was in the air and they don't know if something's happening to them. So just something to keep in mind. You know, we kind of saw it a little bit with the spouse of the husband, you know, for good reason. She had a very severe reaction to it, but was just exposed because she was in the car with him. So just something to keep in mind for more public mass casualty events. So the meat of the presentation here. So art of communication, I called this slide. What went well? Opportunities for improvement. These are all going to revolve around communication. Illinois Poison Center was involved early. Obviously, I reached out to them very early, and they were already notified by someone, but they had very limited information from the scene. Obviously, as the EM pharmacist, I was highly engaged throughout the whole process in helping coordinate different aspects of care in the emergency department. And then we'll find out on the next slide, our patients were successfully managed. So the meat of this is the opportunities for improvement. So incident command activation, it took a little bit longer than we would have liked for our hospital's incident command to be activated. Our administrators in pharmacy were notified through us, you know, of what the issues was happening versus, you know, at a higher level for our system. Of course, this is going to typically come from us initially. Obviously, we're the place where these patients are coming in, the first notification. So, you know, there are opportunities for improvement, but typically it is going to be us first notified. Chemical identification issues, we discussed those in the beginning, confusion on what chemical it was, and we could not get anyone from the scene emergency management team to, you know, provide any additional information or even who that contact person was. So coordinating with your county's emergency management team, again, this happened a county over, so even, you know, your surrounding counties would be good to look into. Antidote inventory awareness. So this is the important one for us as emergency medicine pharmacists. Illinois Poison Center was told incorrect information regarding patient transfers. So again, they were surprised that we had patients coming, not to mention walk-ins that can happen. And then the hospital where all of these patients were supposed to go, come to find out later, only had enough pyridoxine to treat 1/3 of one patient. So they had 5 vials, which is 500 milligrams. So roughly 1/3 of a dose for an average 70-kilogram patient. We actually had 54 vials at our facility. And that's enough if you did the napkin math to treat 3 patients, at least for that initial dose. And so I feel like some coordination, and I'm not sure what the actual solution of this is, but coordination with Illinois Poison Center or local state poison centers. I do know that they do like a survey of what kind of antidotes you have in stock, but that's just a brief period in time that they kind of do that survey. And so, you know, them during this mass casualty, I think a good idea would be to have contacted the local area hospitals and get a real-time inventory of those things before decisions were made. But Illinois Poison Center was not directing these patients to the hospital. It was the emergency management team. So you could see how convoluted a lot of this gets. Inter-hospital communication at the scene and early on, only through official channels. The partner hospital or the other hospital in town was notified. However, we weren't. We were just merely notified by a phone call from a sheriff. And then finally, decontamination process. Decontamination was not provided at the scene. Some of these big facilities have different ways to decontaminate these exposures on site. So the exposure does not continue to carry out into the community, into the ambulances, to staff in ERs. During this incident, they did not do that, so they were deconned when they arrived to our ER. They also, if you look back at the cases, referred people to the ED who are not transported via EMS, and they could stop at a gas station. They can do all these other kind of things, before they make their way to the ER, exposing even more people. So, just some highlights there for opportunities of improvement. Our patient disposition, as I mentioned, all patients were successfully managed in our ER with supplemental oxygen, corticosteroids, and albuterol. Final outcomes for all of them, like I said, all 8 patients evaluated, no severe toxicity, no pyridoxine required, no admissions, no delayed complications identified. The total for the incident for all of the hospitals in the area was 18 patients. 8 of them were transported via EMS and 10 walked in. As far as our hospital, we received 6 via EMS and 2 walk-ins. So I just wanted to cover some other considerations. So while this was all happening, I still had to manage the rest of the department. So we had patients in severe DKA, patients intubated, other things going on. So it's important to keep things moving and make sure that while you're doing all this, you're still checking in on that patient flow that you typically have. You can review current protocols on what happens during mass casualty or disaster events, both internally and externally. And as far as internally, this could be all of your ADMs go down, or someone hacks the hospital system, or you have a fire that, cuts off different access to things, or you are getting patients from that that are employees of the hospital, or external, like we've talked about today. You want to identify critical medications and antidote shortages early. Again, typically at our site, we kind of check in on our antidote supply once or twice a year. However, with shortages and other kind of things that generally happen, especially for specific incidents like this, you need to evaluate rapidly. And depending on the specific type of event, you want to try to anticipate needs early. So, if there's a lot of trauma involved, you might need anesthetics, RSI kits, sedation, pain medications, those kind of things outside of your normal power levels for your ER. And then finally, keep communication open and information shared amongst the team. As you can see, things rapidly evolve during this situation. I printed out hydrazine toxicity sheets out of the tox resource that I had. And then IPC recommendations, and I printed these out for all the nursing stations, all providers on shift had copies. So I was running around talking to all these patients and getting current updates on them all, but everybody had, the text information at least readily available for themselves. And then finally, most importantly, I reverse, the information flow to Illinois Poison Center when I was able to have that conversation with the gentleman that worked and discovered the spill locally and what the chemical was. Briefly, we're talking about this nuclear power plant, and not everyone lives by a nuclear power plant, but other type of mass casualty events. So just our hospital in the last couple of years, and I've been involved with all 3 of these actually. I just am a black cloud, I guess, for the 3 of us that are full timers here. But March 2024, there was a mass stabbing in a neighborhood locally. 4 were killed, unfortunately, and 7 others were injured, and we got many critical patients, including 1 pediatric from that. March 2023, tornado collapsed a concert venue where 1 person was killed and 48 were injured. Those were distributed across all of our hospitals in the area and was actually closest to our critical access hospital that falls under us. So I drove out there, even though we have no coverage there, but it's our same provider and nursing group. December 2020, there was a mass shooting at a bowling alley where 3 were killed and 6 injured. So, there's a span over a couple of years there, but just around the country the past few weeks, I took a look. Actually, it's popped into my Apple News just while I was preparing this presentation. But just in the past couple of weeks, there was a paper mill chemical explosion in Washington that killed 11 after white liquor, which is sodium hydroxide and sodium sulfide. A big tank of this exploded. Additionally, 400,000 Californians were evacuated after a chemical leak at an aerospace facility. There was a huge fire and major explosion in New York City at a shipyard where 3 critical patients came to the hospitals and 16 injured. And then finally, a chemical leak in April at a refining facility in West Virginia with 2 dead and 30 people injured. So, this is happening all over the country, seems pretty frequently, so could be coming to an ER near you. Just wanted to share resources briefly for everybody. These are hyperlinks. I'm not sure how this will get shared out, but at least you can Google search these terms if you need to. But ASHP Emergency Preparedness Resources has tons of information there. The Centers for Disease Control and Prevention, ChemPAC. This is a resource that you can look into that is part of the Strategic National Stockpile, and this is for nerve agent antidotes. There's also a government resource, Government Office Administration for Strategic Preparedness and Response. American College of Emergency Physicians has a lot of guidelines and statements that help with planning and preparing for these mass casualty events. State poison centers can serve as a regional toxicology command center during some of the widespread mass casualty incidents, as well as helping with antidote acquisition and resource coordination. And then don't forget, especially in this instance for us, about your good old MSDS that I'm sure, take in all of our annual trainings at our local hospitals. One thing that I did fail to mention on our incidents and events around the country is each incident requires different personnel, equipment, and medications. And sometimes you could see in some of these events, one incident can combine multiple mechanisms, including trauma, burns, chemical exposures, or blast injuries. So in this specific case with our nuclear power plant, we didn't need trauma surgery. In a lot of these incidents we would, but we did rely heavily on our respiratory therapy team with all of the NEBs and everything else going on. So important to know your resources there. So again, these are some resources that will help you take a look at your preparedness and kind of what your antidote stocking decisions are. ASHP has a good antidote stocking resource for everybody as well. In summary, chemical MCIs, specifically in this incident, treatment decisions frequently must be made before complete information is available. Early coordination with poison centers, toxicology resources, pharmacy, and incident command is critical to avoiding delays in care and antidote procurement. And finally, familiarity with hospital local protocols can promote efficiency during these mass casualty events while also maintaining workflows for other patients. This leads us to our first assessment question for the night. A nuclear power plant, coincidentally, an employee presents after a suspected hydrazine exposure. Which toxicity is most directly related to hydrazine-induced depletion of pyridoxine? Is it A, methemoglobinemia, B, seizures, C, bradycardia, or D, renal failure? All right, so the correct answer is B, seizures. Hydrazine inhibits the pyridoxine-dependent pathways involved in GABA synthesis, and the reduced GABA levels can lead to the CNS excitation and seizures. And pyridoxine is therefore considered the antidotal therapy for significant hydrazine toxicity. Why the other answers are wrong, methemoglobinemia can occur, but it is not the primary pyridoxine-related toxicity of hydrazine. Bradycardia is typically not a hallmark manifestation of hydrazine toxicity, and renal failure can be seen in severe cases, but much later in the course of the patient. Our next assessment question here: during a developing chemical mass casualty incident, multiple sources provide conflicting information regarding the involved chemical. What is the most appropriate initial action? Is it A, wait until the chemical is definitively identified before preparing treatment resources? B, prepare for the most severe plausible exposure while continuing information gathering? C, assume the most recent report is correct? Or D, delay patient evaluation until incident command confirms details? All right, I'm seeing a lot of B's roll in. B is the answer of the day. So yes, B is correct. These situations are evolving rapidly. Early contact with poison center consultation, antidote assessment, and treatment planning should occur while other information continues to be verified. We've seen a lot of these things that I just mentioned in this case that we presented today. Option A, delays just will delay the care and the preparedness of the team. Option C, sodium metabisulfite was the correct most recent answer at one time during the course of this case. And so that ended up not being the right answer at the end of the day. And then finally, patients may arrive before information is finalized for option D, especially from incident command. That could be quite a long time before they confirm what's going on from incident command at all levels. So thank you all for joining us today. I hope you guys took a little bit away from this case. It was pretty, clenching to hear, there's an incident at the nuclear power plant initially when that call came in. But, we all step up to these challenges that present to our ERs every day around the country. I hope you took a little bit from this presentation in your own preparedness, and you can go back to your facilities, review your antidote list, see what your schedule is for reviewing those, and touch base with your poison centers and what they recommend as well. At this point, I'm not sure how much time we have here for a question or two, or anyone has any discussion or anything they'd like to share. Thank you.
Hey, David, great presentation. I actually dated myself a little bit back when I was doing PGY2 residency in 2015. That sounds so weird saying that. I remember looking at the same exact thing with pyridoxine, except just it was carrying on hand, not for hydrazine, but actually for isoniazid overdoses, just because a significant patient population that was taking drugs for TB and just trying to keep it on hand. And they're all like, I looked at the shelf and it's like they're talking about just not restocking the pyridoxine because it's like, oh, we just keep expiring it and we never use it. So let's just remove it from stock. And I was like, no, I know we keep expiring it, but it's relatively cheap and it's one of those drugs we need because if we don't have it when we need it, then that's the only thing that's going to treat the seizures.
And funny that you had just brought that up, Nick. So I actually, despite, everything that happened with this case, I checked on our current inventory as of a little bit before this presentation today. We have 25 vials. So half as many we had that day when, when the incident occurred. So maybe 1.5 patients worth. So definitely something that we'll be reviewing going forward and making sure that we stock enough of it.
Dave, I think there's a question. So if your place doesn't have extended pharmacy coverage, what would you do to prepare the rest of the pharmacy staff or the inpatient pharmacy staff for response?
Yeah, Laura, I see your comment in the chat here. Laura, that's a great question. And it's a difficult one and one I struggled with, especially with the debrief with my leadership. And, I was the one that reached out to schedule the debrief with my leadership as well. That brings up another good point is, reach out to your leadership after these events. They're busy. They attend some high level debrief of it. But, my meeting with my administrators that I put together and scheduled, they took a lot more from that they were unaware of and able to bring back to the table as well. So a good point to bring up. But as far as if your ED doesn't have that extended EM coverage, in talking with our administrators, as much as we're working on the ground and doing this stuff, they're able, if that incident command gets activated, they're able to pull in resources, able to talk with central pharmacy. I was texting with my administrators during this event that was going on, and they were asking me like, hey, do we need to start reaching out to UW-Madison, that we're under and see what their stock is. And, they were able to help assist in some of those decisions. And so they would be kind of helping with that central pharmacy aspect in terms of procurement and those kind of things. And I was staying in touch with them as the situation was unfolding. And I was like, nobody's really coming in with these CNS symptoms outside of like the hand tingling and stuff for right now. So I think we're good. We have enough supply for 3 patients if they start seizing. But yeah, start trying to locate some stuff. We don't need to pull the trigger yet, but just start locating stuff. So I feel like the admin team or the pharmacy representative on incident command would have to be kind of the central point for them. And they're also able to coordinate, like in our scenario with the multiple hospitals, they might be in contact with the directors of pharmacy over there. And, again, stories are changing so rapidly, but, I don't want to be the guy in the ER, being me. I'm like, do not give any of our antidote out because we have these patients showing up. But if there's a higher level, emergency management decisions being had, maybe that's not the right answer to tell Central to not give any out, but they know where patients are going or are being told where patients are going, which, as you can see in our scenario, didn't play out that way. But, you need someone almost in that position that can handle that part while you're taking care of the patients in the ER. And like I said, for that tornado, one of my colleagues, Veronica, she was working in our ER, and they were starting to get patients over at our main large hospital campus. But one of my friends was the physician in our critical access hospital. I called him and just said, "Do you need help?" And he's like, "Yeah, I have people walking with like dust, like looking like they were from 9/11 from the collapse of the concert venue into the 6-bed critical access ER, of which they had other patients stuff at the time too. So I just got in my car and floored it out there. And again, that was just me improvising at the time while on the phone with my directors of pharmacy, talking to my colleague Veronica that was in Armenia or over here, and just being there. So I think all of us show up when the call goes out, and so I think that's the best you can do as well.
Thanks, Dave. Definitely good presentation, especially real world situations, and when you're the only person there or a small amount of people. Great to see your experience and keeping it all together. Thanks for talking.
Yeah, thanks for having me. Thank everyone for bearing with me too.
All right, everyone. Next, going to have Dan Hayes talk a little bit about his experiences in emergency medicine. Some people call him an OG of emergency medicine, and I think definitely part of that. Dan is definitely an original guy. One of the early Dan stories I remember was him walking through PPS with a short sleeve T-shirt and his shirt sleeve tattoos, just going in the wind there. So definitely original guy. So please take it away, Dan.
Thanks, John. Actually, it was funny. I think that year I had shorts on as well. And somebody put their application in my box at PPS. And I walk up and they saw me and grabbed their application and walked away with it. So, gotta love it. Well, hello, everyone. Daniel Hayes, old school EM professor or EM practitioner. Thought I'd start it off with anyone hear any interesting stories, gossip, lurid tales that feel that they might like to address before I get going.
Damn shame about Justin.
I'm sorry?
This.
And I could not make that out. Well, so anyhow, was in Rochester for the first 8 years of my career. Next 6 years at the University of Arizona Medical Center when I should have taken a break. UMC eventually went bankrupt and was bought out by Banner Health. But I was also starting to too much trauma, not enough personal time, and started almost essentially running. Didn't know if it was running from me, running from whatever, but started to jump from place to place to place. After I left UMC, it's kind of funny because I went to Banner Desert. I was there for about a year and pissed off the director from Banner Desert so badly that when she rose in power throughout Banner, she closed my program at the PGY2 at UMC in Tucson or Banner, UMC, whatever you want to call it. So definitely throughout the years, high IQ, low EQ, and managed to piss off a lot of people. But anyway, it was a year here, a year and a half there. I landed in Vegas at the end of 2017. 2019, helping to intubate a 2-year-old with a viral infection. I came down with the viral infection and developed narcolepsy out of it. Living in Vegas where healthcare is atrocious. I always say if you're sick and you're in Vegas, go to the airport. But Nevada's 49th in the country for quality of care. I wasn't able to get a definitive diagnosis until a couple of years later when I went to Mayo in Arizona. But but nonetheless, wasn't really able to practice in the ED anymore. I couldn't do the 10-hour shifts, the 12-hour shifts. At the same time, personal life was falling apart. I was jilted. I couldn't function between the sleep disorder, not knowing what was going on, literally driving to essentially tie the knot and having it called off. Pulled over, didn't know what to do, had myself admitted for almost a month. Again, it was emotional things that had I had the proper tools all throughout the years, I probably would have taken a break from the ED or working EM and done something else. But I wound up getting out. Life was okay. I was lived in Vegas, still just working inpatient. When a few months after my discharge, I had the extreme displeasure of meeting somebody with borderline personality disorder. For all of those who have read about it and have never met somebody with true BPD, it's terrifying. But this person essentially wrecked my life. At one point, they kept me awake for over a week straight. I became suicidal. Don't have any recollection of it, but I took home a vial of sucks from work. Again, don't remember it, but next morning said, please get rid of this to this person. They're like, fine, whatever. Several months later, they took the vial of sucks and a bag of their own meds to where I worked. Got me terminated, but also I lost my Nevada license. From losing Nevada license, my Arizona license was put on a 5-year probation and essentially was unable to get a job as a pharmacist. Started working through the probationary steps, was able to have my probation cleared in 3 years versus 5. I was working for industry. Please don't hold it against me. It was the only thing I could actually get a job doing. And finally decided about a year ago I wanted to start practicing again. I couldn't get a job. Licensed in Washington, over 1,000 applications, 1,000 rejections. My final EM rejection was last week when they said they wanted somebody who had more recent hands-on experience. My response was, well, you're taking somebody who's read the book rather than somebody who wrote the book. And again, a little immature, but at the same point, it's just like, okay. And I've been out of it long enough, but emergency medicine, things don't change every day. Things don't change every year. You may have some new antibiotics, you may have treatment algorithm updates, but it's pretty easy to jump in and out. Going back a little bit, and sorry if I'm jumping around, losing my license was devastating. After I was fired from my job, I connected with the Nevada group for mental health, alcohol, drug use, etc. And the Nevada Board of Pharmacy didn't care. They were just like, nope, we're taking away your license for 2 years. We don't care that you've been working with the program. We don't think you should practice, period. Thankfully, over time, I was able to get Nevada's license back. It's inactive because we'll never go back to Nevada. But long and short of all of this is for people who've been out there practicing long term or even short term, one of the things I can't recommend enough is a good therapist. And you ensure that they are someone to work with, not just a therapist, make sure they are decent, that you mesh well with them, that it is that good working relationship. You could go through a dozen or 2 dozen before you actually find that person to work with. Work with them to not only fend off some of the trauma that you see at work. Your average level 1 or your level 1 trauma center needs 1,200 activations a year to maintain their status as a trauma center. In Tucson, we were seeing about 4,500 a year. So we might crack 5, 10 chests a day. We would have mass casualties daily. And you eventually start getting numb, and you're going home and you're carrying that with you. You have your peers who you work with who might say, "Hey, are you okay?" And if you say, "Not really," probably they aren't either. And they're just going to move on and do their job. But you may have good friendships with those people at work. But again, you need to find that group outside of work who you can sit down, talk with, share with, purge, whether it be a daily basis, a weekly basis, because eventually you're going to start carrying this stuff and it is going to impact you. It's going to impact your daily life. It's going to impact all of your surroundings, your interactions with people. Besides some of the I don't know. One of the things that I wish that I had recognized very early off in my career was the high EQ and low EQ. I'm sure people on the call who have worked with me used to hear me crack mom jokes. I remember doing a Southwestern trauma conference, and I was when you're dosing an opioid for somebody who's really big, I don't know, like my mother, and the whole room went dead quiet. It was juvenile, it's immature. And it was kind of my way of trying to deal with standing in front of 1,000 people and speaking. Hindsight, not really mature, and it might be a quick laugh at the time, but it really does reflect poorly upon you over time. And the more and more stuff you do like that, the less and less you are going to be accepted as a professional. Whether it be the people you work with, whether it be the national organizations. I know I frustrated enough people at ASHP that I stopped being asked to do presentations. Don't know if it was completely me or Frank Lavecchio who did the last presentation with me, where the complaints afterwards there were hundreds about his language, his inappropriateness, his innuendo. I was shocked during that presentation and actually kept trying to get him to either be quiet or steer the conversation away. Anyway, a lot of it can be funny at the time, but it really does reflect poorly upon you at times. I am happy to announce that I finally have a job offer in Maine. So we'll be moving from north of Seattle to Bangor, Maine, where I guess I'm kind of bummed that Stephen King doesn't live there anymore because he would be a great neighbor, or so I've heard. But we'll be living in the town also known as Derry, which is where all of his stories are based on. One of the other aspects of life that has really, and I can't be thankful enough, is having a great partner. We've been together for 5 years, and this person has stood by me through good and bad, but also helped me recognize some of the emotional shortcomings. My old business cards just had my name, and below it said nobody. Again, kind of funny, kind of amusing, but not really inappropriate for being professional. But again, very honored to be here and to give this presentation and be able to talk to people and kind of share what happened throughout my career. In school, or throughout our career, we always hear about people losing their license, whether it be my license is on the line because of an order, or my license is on the line if I'm verifying something. But I lost my license due to somebody with significant mental health illness that I knew nothing about, and have had to recover from everything, not only the trauma from the career, but I was eventually homeless at one point. And if it wasn't for Chris Edwards, I'm not really sure what would have happened. You start sleeping in a wash in Tucson, and you're like, you can't believe that your life came down to this. So, the trauma from the practice can wreck your life if you don't have the right tools to deal with it appropriately. And I definitely didn't have the tools, whether it be quality therapist, family network, friends outside of work. And those are all things that people should cultivate those relationships and hold on to them, because without them, your road could become the one that I went down. And I would introduce my partner, but she's not feeling well and got told absolutely not. So I know, kind of brief, kind of just verbal um, uh, diarrhea. But anyone have any questions? Anyone want to ask anything that happened during that period?
Thanks,
Yeah,
Tim,
Dan.
for sharing. I'm curious, how did you notice any time before that, or when did you really notice things were getting rough, or you were having a rough time when you were in practice?
When I was in practice in Tucson, the seeing multiple people cut open daily. Um, and at first it's like, whoa, a thoracotomy, that's kind of cool. Or you see the dissection and they're using a roboa for the first time. But eventually that stuff does start to wear on you. And when it is nonstop, nonstop to the point that you're doing compressions and your resident is force feeding you because you haven't been able to stop to eat for 12 hours because it is constantly coming in. And I think it was around 2012, about 2 years before I left the U of A, that I started to search for another position and wasn't really sure why, but there was this driving force like, I need to get out of here. And when I finally did leave, I was like, I don't know what to do with myself. Like, I don't want to go back to the ER, but what can I do with my education? I thought of either A, moving to the Everglades and helping to catch Burmese pythons, or taking the postal exam. Because again, at the point when I left there, I was numb. Um, I I put in my resignation. I had enough PTO to last almost 6 months, but I could barely speak to people. And that was 2014, and I still kept practicing for 5 years after that.
Gosh, sorry to hear that for you. There's some questions definitely. When this was happening, did any colleagues or leaders, at the hospital, I guess thinking, offer any assistance or recognize
It
anything?
was window dressing. A lot of it. Do you need any help? And I remember saying once to my director, yeah, I really do. And it was told, well, then you should go get some. Or colleagues like, are you okay? And me saying, not really. And they're like, well, and they would move on. So I think there were some people noticing, but there really wasn't. Again, it was window dressing rather than legitimate. Um, he needs help, and we're going to help find it for him.
Because at that time I still think, but did they have any free or opportunities at the healthcare institution, or?
There was a EAP,
Mhm.
but you get three phone sessions with somebody you don't know, and you might as well just pick up a phone and dial a random phone number from the phone book.
And I liked your point too about, I think it's definitely very real. Not that you're not friends with the people that you work with, but it's almost like bonding through trauma. Like they're seeing the
Right.
same things. It's hard for them to maybe relate or be compassionate when they're probably going through a lot themselves.
Exactly. And John, I don't know if you mind being the person fielding questions. I'm on my
Yeah.
phone because
Oh, yeah.
brilliant person I have left my laptop at home.
Brian Gilbert asked, what would you tell yourself today, 15 years ago, if you could?
Even before 15 years ago, 25 years ago, I took my MCATs and I did well, and I wish I would have pursued that. Pharmacy is nowhere what it's supposed to be. And I was director at large for the section of clinical scientists and specialists with ASHP 12 through 14, and kept trying to bring up there's too many schools, there's open admissions. We as a profession need to do what the medical schools have done, limit admissions, limit training programs. And ASHP was like, we don't want to hear it. And it's because they make money off of people. And again, this was 2012. When I went to school, there were 57 pharmacy schools. 2012, there were almost 200.
Yeah, I think that's definitely changing, but yeah, it had a bad effect for some people for sure.
Well, I mean, now it's you don't even need decent grades to get in. You don't need PCANs to get in. I was the last class of getting both my BS and PharmD, and the amount of education that people are coming out with, it's I couldn't take pharmacy students because their lack of knowledge was so significant.
Yeah, especially for someplace like the emergency department, it's difficult for people to be trained enough or to maybe sequence that. There's a question. What would you recommend, or what would you say if for us or someone that notices that your colleague is having difficulty or signs of burnout? What would you recommend?
I would recommend insisting that they take some time off. If they're not willing to take them outside, have a heart-to-heart talk with them, come to Jesus moment that if you're noticing it, other people are noticing it too. And eventually they will go down the rabbit hole where they might not be able to come back out of it. As a program director, I would always tell my residents, go outside, take a break, get a breather. 8 hours, you're done, go home. Knowing that you start spending too much time in there, it starts impacting you. Or you might see something that impacts you and you need that break. But I was never practicing what I preached. And had a colleague insisted that I take some time off earlier in my career, I probably would have. But I was working 40 to 60 hours a week, traveling to lecture on weekends. I never had time off.
And then someone said, why did you leave industry? What happened there?
So the first part of my career was great. I originally went into medicine or pharmacy because one of my friends was diagnosed with lupus. And the first drug I worked on was anifrolumab for AstraZeneca. My contract with anifrolumab ended, and I was put on an oncology team. And to have to try and manipulate such horrible data, this drug is going to cost $1 million plus a year for an extra 3 months of survival. When that contract ended, it was a relief.
Yeah, some of that. I've never worked, but in the end, talking to the non-pharmacy people that, you have a drug company, and I mean, they are doing things to help people, but still in the end, it's a business. They're not healthcare professionals. And I don't mean that to criticize them, but that's not their motivation as a company.
Now,
So
especially in America, when the average company is a 2 to 3% profit margin, and the average drug company is 20 to 30% profit margin.
There are more questions.
And also, I really miss patient care. Um, I miss being able to make a difference. And whether it be the trauma patient who comes in, you take their shoes off and everyone's gagging, and you pull some bicarb off and spray their feet, um, to whether it be antibiotic therapy, doing the right sedation, because physicians now don't know what they're doing. Um, to be able to make that difference and know that you're doing something for the patient. I miss that.
Especially in the ED where it's so very, immediately you just see the effects too. Anything specific for or more specific or other things for people in EM? So definitely you're saying taking time off.
Taking
Anything
time
else?
off, ensuring a vacation. The the 7 on 7 off. It might be a great lifestyle, but it starts getting harder to deal with. Having the support, a very tight knit support group outside of work, essential. There's a lot of people on the line here. Pick up the
Yeah,
phone and call somebody and say that you had an awful shift. You just need somebody to sit with you.
yeah, there's definitely those days for sure.
Mm-hmm.
And definitely if anyone else wants to, please, you can unmute or any other questions. There's definitely some good conversation going on about appreciate you being so honest and sharing. So I think that definitely have to echo that, and definitely talking about the workload in the ED and precepting students and that. So echoing some of that as well.
Yeah, I mean, our earlier presenter talked about, you've got a mass casualty. Um, when you start dealing with that every single day, when you've got 3 or 4 traumas, you've got a cardiac arrest, you've got a code up on the floor that you're the only person in the house that's ACLS trained, and and to have to keep running, um, you never take time for yourself in that.
Yeah, for sure. That's in smaller places. It's you play so much more of a part of all kinds of care, but even in bigger places too, because sometimes then you have just more activity. Always a risk just in the environment.
The pediatric deaths are hard to deal with, where mom's boyfriend put somebody in the washer because they wouldn't stop crying, or uses them as a baseball bat, and to have to try to deal with that afterwards because everyone's devastated.
It's always harder to rationalize, not that it's not good for anybody to die, but with kids, it's just so hard to get that right in your mind.
Mm-hmm.
Yeah, and this is Nick. I think one of the things that changed for me the most was, I had lots of peds experience during my residency, but then my first job afterwards had really none, and even kind of like the job after that. But then when I was at some place for a year and a half, they had a peds ER, and that time now I had kids, things changed a lot differently for, perspective and viewpoint because I had kids, and then seeing it now, like it just like it didn't feel the same, and I actually had to like step away for a couple minutes after we had like a really bad like cardiac arrest and like I think it was like a 2-year-old. And yeah, things change, and you think you're okay, but then it seems like you're not okay.
Yeah, I had 2 brothers, 6 and 8, when I was in Rochester, that came in with meningitis, both talking, and within an hour they were both dead. Um, and I took time off after that because I couldn't function.
Dan, Jim Pruitt here. One of the things I've been trying to think about and figure out how can we look at this from a system perspective is what do you think we can do? If you had a magic wand, what can we do as a group, as a society? What kind of guidance can we put forward to think about the longevity of EM pharmacists? 'Cause that's the tough question.
Yeah, I mean, I think a phone tree, have people's contacts available. Have really strong leaders who are willing to listen, but also help guide someone. Some of the work you have to figure out on your own, build your support group, therapist, family, friends. This group can't help with that, but they might be able to come up with, whether it be a list of providers, whether it be state by state or, again, a buddy system where you put out a phone list and have people contact each other. Are you willing to be this person? Whether it be like AA, your support, or your sponsor.
That's a good idea. It's something we can easily put together.
And Jimmy, we could also even have like I kind of talked about this throughout this idea too a while ago, but maybe resurrected, just even having, kind of like a, just like a virtual happy hour sometime, maybe like once a month, just everyone just kind of chill, vent, and just hang out.
Yeah, I think that's be big things, and I obviously see a lot of people putting some stuff about how this can be another thing we can do at the conference as well. It's like let that be the vacation, let that be another component as well to help us kind of recoup there. So I think those are big parts. And for you guys that don't know, that's really been helping out, kind of seeing things from the top down, as far as from the organizational perspective. And these are the type of things that we'll want to continue to do. And I just want to kind of put out there for you guys who don't, follow the history of EM pharmacy. I've said it right before. Dan kind of laid out what EM clinical pharmacy is today. And I think you guys realize I'm infatuated with all of that, but I think him being able to be here and to kind of give us these thoughts, and if you count him, Frank, and John, some of the people, the coaching trio, I would say, of them is incredible. There's people from all over the world in the early 2000s that was coming to Rochester to be with him. I see Nikki Aquesto on here as well. Again, all the individuals there. I believe that there was two programs at the time. It was Detroit.
So it's us in Detroit, and
Yeah.
Detroit was accredited first because we got snowed out in Rochester.
So just the number of people, I realized one of my colleagues trained in Sarasota, and I remember their program got started because they started with your EM PharmD project back then. So a lot of the information that he's passing on, I would say is the godfather of EM clinical pharmacy, and a lot of the work that was done. I really just want to appreciate you for coming on, but more importantly, appreciate you for sharing your vulnerability, sharing, you can be really great, but people see you differently. And I just want to make sure that if I have anything to do with it for the rest of your time that you're around here, that we kind of could continue to highlight and spotlight the importance of your contributions to what EM pharmacy is today. And my hope is that you continue, and SEMP is a place that we collaborate with others, but we're going to be the group that makes sure we hold on to our pioneers. So I just want to thank everyone for coming on. I know it's a lot more questions, and I believe that we can probably just send all those questions to just our email, so we just don't bombard him. We can kind of pass along to him. But yeah, just I'm super thankful.
Yeah, Dan, thanks for sharing and being open with it. I think that's maybe part of it as well. It's not good things that you went through, but that you're able to share it with people. If people are afraid or just keep it inside or that type of thing, hopefully, I hope that can help people as well, that it's okay to talk about it and it's okay to share your feelings.
Yeah, I think it's essential, because if you don't, again, it will eat you alive.
Well, thank you, Dan. Definitely, if anybody has questions, please reach out on SEMP or to any of us, please, if you have any questions, and we can get back to you. We'll try and do this again.
All right, guys.
Thank
So I'll
you.
be sending you guys an email with some follow-up on the continuing education side of it, and we will get it put it on the website. So we already have it halfway done. I just got to convert this video over. So you guys get an email probably Monday morning about all the CE. Thanks again, guys. Have a great day.
Thank you.
Thank you.
Thank you.